The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thanks so much for joining the Fight Colorectal Cancer webinar. My name is Sharon Worrell. I'm part of the Fight Colorectal Cancer team and super excited to welcome everyone today for the Recurrence What Now webinar. So our speakers today, we have Dr. Niloufar Azad. She is joining us to give a really great presentation this morning or this afternoon if you're on the East Coast. A couple of technical things before we get started. We are opening for questions at the end of the webinar, but as questions come up for you during the presentation, feel free to type them into the panel on the right side of your screen. We'll be able to see them on our end and we'll address your questions at the end of the session. The webinar is being recorded and we will post the recording of the webinar in addition to the slides at fightcrc.org/webinar. So make sure that you check it out after the webinar presentation. And of course, we do tweet during the session. So if you do have a Twitter account, please follow along using the hashtag CRCwebinar. Fight Colorectal Cancer offers a number of free resources to those who need them. We have our Tabooty podcast where we talk about trending and taboo topics that relate to colon and rectal cancer. We have our new screening mini magazine that talks about all things screening and prevention for colon and rectal cancer. And we also have our late stage MSS CRC trial finder, which is a curated list powered by patients. And you can find that at trialfinder.fightcrc.org. The information and services provided by Fight CRC are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately, and in an emergency, call 911. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And finally, Dr. Azad is an associate professor of oncology and a member of the gastrointestinal oncology program at the Sidney Kimmel Comprehensive Cancer Center. Since she's been on faculty there, she has been the PI on numerous early phase clinical trials in solid tumors and GI cancers. She's a clinically active medical oncologist and is the co-leader of the NCI-funded UM1 Developmental Therapeutics Clinical Research Program at the SKCCC. She is a member of the Epigenetics and the Colon Cancer Stand Up to Cancer Dream Teams, a member of the NCI Colon Cancer Task Force, and so much more. So Dr. Azad, thank you so much for being here today.
Well, thank you so much for that introduction. Are my slides up?
I am making you the presenter right now, and then I'll let you take it from here. Oh, perfect.
Okay, perfect. All right. Well, wonderful. So what I'm hoping to do today is for us to be able to talk through a little bit of what we do standardly for our patients when someone is diagnosed with colon cancer and they're going to undergo therapy to reduce their recurrence risk. What can we do to help reduce people's recurrence risk? And then what happens if a patient does have a recurrence? So the first part of the talk is really going to be looking at what really is standard of care for early stage disease. And early stage disease in this setting, I'm really talking about people who have from stage 1 to stage 3 disease. And then after you complete whatever treatment is appropriate for your stage of cancer, what kind of surveillance is the right surveillance to do? And what can a patient do to modify their risk and decrease their risk of recurrence that they have control over? And I'll also try to bring up a few national and local clinical trials that might be interesting for patients depending on where they are during their treatment journey. And then finally, we'll talk about what happens in the event of a recurrence. What are some of the basic treatments that we go through? What can we do to try to do our best to potentially still cure patients of their cancer? And even if we're in a circumstance where we need to do more chemotherapy or experimental therapy, what kind of treatments are available for people? So looking at what is the standard treatment for patients that have colon cancer, I want to first speak to what it means to have low stage versus higher stage disease. So Stage 4 colon cancer means that the cancer, at the time that it's diagnosed, has already spread outside of the colon to a distant organ or to distant lymph nodes that aren't around where that colon or rectal cancer is. And that's stage 4 disease, and we'll speak a little bit about what you do in that circumstance. But today we really want to focus on earlier stage disease, stage 1 to stage 3 disease. And that's really when the colon cancer or the rectal cancer is confined to the area of the colon and the rectum. And if you have stage 3 cancer, then you also have some lymph node involvement in that same area where that colorectal cancer is. But otherwise, there is no distant spread of treatment. And colon cancer and rectal cancer, these are cancers that, if they're diagnosed early, are eminently curable just with surgery. So if we look at this slide here, if you look at early stage disease, so if people are undergoing their standard colonoscopies and doing proper screening, their cancer really should be caught either at a stage where it's a polyp and a precancer, or hopefully at a stage where that cancer is still very much just confined to the colon or the rectum without any lymph node involvement. And in that setting, really all we do after surgery, everyone gets surgery, but after surgery, all we do is observation for those patients. So adjuvant basically means the adjuvant, the thing that we add on to surgery to make outcomes come out better. So for the earliest stage disease where the cancer only has gone through the wall of the colon, but it hasn't involved the lymph nodes, observation and surveillance is the right thing to do for people. Next, though, if a patient has lymph node involvement, that's what this N1 means, the involvement of lymph nodes, that's when we build in chemotherapy. And chemotherapy is very effective for patients with colorectal cancer. It reduces the risk of recurrence by 50%. And depends on how many lymph nodes a person has positive. If at the time of surgery they have 4 or less lymph nodes that are positive for cancer in them, 3 or less, excuse me, then 3 months of chemotherapy might be all that they need. If there are 4 or more lymph nodes that are positive, then 6 months of chemotherapy is what's recommended. And that 3 to 6 month range is a little bit of a gray area based on some really large clinical trials that looked at whether 3 or 6 months were better in that early stage, low risk setting, but definitely at least 3 months of therapy are indicated for people that have lymph node positive disease, with 6 months being appropriate if there are more than 4 positive lymph nodes. Now that's what we do with colon cancer, but rectal cancer has a treatment paradigm that is a little bit different, and that's because the blood supply to the colon versus the blood supply to the rectum is different. And the blood supply to the rectum is such, as well as the lymphatic drainage, that there's a higher risk of patients having a recurrence locally in the pelvis. And so if you look under the microscope at a specimen of a tumor that is from the colon or from the rectum, you won't necessarily be able to tell under the microscope whether it's colon or rectum. The tissue looks the same. What the difference is that if you've got rectal cancer, you may well need to have radiation involved in your therapy. And so for patients that have colorectal cancer, so disease in the rectum that has involved any lymph nodes, those patients deserve some radiation as part of their treatment. And we really like to do that before a patient goes to surgery. There have been studies that have looked at whether people should get radiation before or after surgery to keep the cancer from coming back locally in the pelvis. And what we found is, while it's effective to do radiation both before or after, you can understand that if you do the radiation in advance of surgery, then when a patient goes to surgery, that entire area that's been radiated, most of it can be removed. So long-term, there's less chronic side effects if you give radiation up front before surgery. On the other hand, if you do radiation afterwards, it's still effective, but now you're going to be living with that radiated tissue in your pelvis for the rest of your life. And so there's just a higher chance of having chronic side effects. There are different ways that radiation can be given. It can be given either just 5 days of treatment, or it can be given over 6 weeks of therapy. And a lot of the difference between why people choose one or other of these radiations is based on what center you're being taken care of. So there are cancer centers like ours at Johns Hopkins where we have now moved to doing 5 days of radiation followed by 2 months of chemotherapy, and then patients go to surgery. There are other places where patients will get 6 weeks of radiation with a little bit of chemotherapy at the same time, and then go to surgery. They're both very effective. It's really become, there's the head-to-head comparison of these have shown differences in side effect profile, but the largest studies that are going to that tell us which is the right way to do are still waiting to be fully reported. Now, what if somebody has stage 4 cancer from the very beginning of their diagnosis? So when their colon cancer or rectal cancer is found, they also are found to have another deposit of cancer, but it's still removable at that time. So colorectal cancer is one of the few cancers that even if you have stage 4 disease at the time that you're diagnosed, it can still be treated with curative intent. So we can still cure many patients that have stage 4 disease from the get-go. And so the general paradigm for this is that if you have limited disease that can be removed, patients will have their primary colorectal cancer removed, as well as their metastatic tumor, if it's in their liver, if it's in their lung, removed. And then in the United States, we usually do 6 months of chemotherapy, just like we would for stage 3 disease. Now we do have to be clear that there isn't really strong data to support this. And for people like me, and many of us that take care of cancer patients, what we mean by really strong data is we like clinical trials where people have been divided into 2 groups. One group gets one treatment, the other group gets another treatment, and they're compared head to head, and we can say group A does better than group B. That's a randomized trial, and that's the strongest way to say that we should recommend a certain treatment. In colorectal cancer, when it comes to what we should do for patients that have metastatic disease that has been resected, there's really only been one very good study that has looked at giving chemotherapy around surgery versus just surgery alone. And initially, when we looked at how people did at the 3-year mark, people who had chemotherapy were less likely to have a recurrence than those who did not have chemotherapy. And that made a lot of sense to us based on what we knew from colon cancer in the stage 3 setting. But as that data developed and we followed patients out longer and longer, at the 5-year mark, that was no longer true. And there was equal 5-year survival for both groups. And so because of this, you can say that the data is uncertain about this, but the American paradigm really is for patients to get the same kind of chemotherapy you get in the stage 3 setting, FOLFOX or CAPOX, following their surgery. So after you complete all of your chemotherapy, what do you do for surveillance to make sure that this cancer is not coming back? And these are the NCCN guidelines. You saw a couple of slides before that also pulled from the NCCN guidelines, but these are the national guidelines that have been created by this group, the National Comprehensive Cancer Network. And this group is made up of high volume centers that have significant expertise in these given tumor types. And these are consensus guidelines that a bunch of different physicians, nurses, patient advocates sit down, go through all the data, and then say, this is what is recommended based on all the data. And we as a research community and an academic community are recommending these things. So in the stage 1 setting, if you only have a colorectal cancer that didn't even go through the wall of the colon, all you need to do is get a colonoscopy after 1 year. And after that, colonoscopy should happen 3 years later, and then every 5 years, depending on if any polyps are found or not. For stage 2 and stage 3 disease, there is a little bit of flexibility. Patients should be seen every 3 to 6 months for 2 years, and then every 6 months for 5 years with tumor markers. This is a blood test, the CEA, that many of you might be familiar with, that get drawn at those visits, and then every 6 months for 5 years. A CT scan done every 6 to 12 months for 5 years. And then the colonoscopy requirements are quite similar. Now, this paradigm of how we do surveillance for patients is really where I see a lot of difference in practice. And a lot of this has to do with who is treating you, how much experience they have, and frankly, what your insurance company will also cover. I find that, for example, in my practice at Hopkins, where we really get a lot of high-risk patients, a lot of younger patients, people whose disease biology has been more aggressive, that we tend to scan more and do more hefty surveillance than what the guidelines indicate. And there are other circumstances where I've definitely had patients come and their doctors are absolutely following guidelines, and patients are wanting to have more chronic surveillance. On the other hand, I've had patients who have come in and are really worried about the radiation exposure from CT scans as well. So it can really span the gambit based on who your doctor is, and of course what your personal feelings are about this as well. But you can see there is a lot of flexibility around these guidelines that is still safe for people. So the next segment, what I wanted to talk about was what can we do, and is there anything that there's data to support lowering people's recurrence risk when they've had this kind of a cancer. And I want to tell you up front about my personal biases, because I think it's really important when we speak to some of these issues about how your doctor comes into this. So there are a whole gambit of different things that people can do, from supplemental therapies, complementary therapies, acupuncture, diet and exercise, clearly dietary changes. And my personal philosophy is that if there isn't strong data, and I already mentioned to me, strong data is a randomized trial. If there isn't strong data to support a certain intervention, then I don't recommend it to my patients, because if I recommended it to one patient, I would have to be recommending it to every patient. And I think a lot of these changes can have a real impact on people's quality of life. On the other hand, I also think that if these are things that people want to do, that of course everyone has the freedom to do whatever they want to do, but it's important to know where the data stands for each of these issues. So I'm going to speak to a few of the things that my patients have talked to me a lot about, and then after we get done with this whole session, I'd love to hear other questions or thoughts about these issues as well. So the first thing to talk about is what's the difference between an association and a causation, especially when it comes to recurrence. Because if we read in the newspaper every week, in the scientific journals every week, there are papers and there are articles that talk about if you take a population of patients, that people who eat more of this are more likely to get cancer. People who are exposed to that are more likely to get cancer. And almost all of what is reported is usually an association versus a causation, meaning that when they looked and tried to identify different things that were common in people who had colon cancer and rectal cancer versus others, they found that there was more people that happened to drink alcohol, for example, than people in those who developed cancer versus those who didn't. But these have a lot of confounding factors, because many people who have a certain dietary style, who might be more likely or have been using tobacco, they may also be people who have a different exercise profile. Education comes into this as well. Access to different foods comes into this as well. So we don't know which of these things really is the causative factor versus if it's just an association. So I think it's very important to be discriminating when you read these kinds of articles. And I gave some examples here of, charred meats, alcohol, tobacco, decreased exercise, exposure to sugary beverages, and especially high fructose corn syrup. These are all associations that have been shown, but the causation factor hasn't been shown in human beings, and it's just a very difficult thing to prove. I do want to pull out the high fructose corn syrup, though, because there has been just recently, so this was just published this year in 2019 in Science, one of our major journals, some interesting data, and this is the only real data slide that I'm going to show, but this is data from the laboratory looking at mice. So I'm going to just talk through this because I find this very interesting in terms of potentially starting to make an argument for high fructose corn syrup being a causative factor rather than an associated factor. And what this group did was it took mice and it gave them, different groups of mice, high fructose corn syrup. It either fed them high fructose corn syrup in their water, or it gave them high fructose corn syrup by feeding them pure high fructose corn syrup versus giving them just normal water. So that's the black line here is just normal water, and these are the high fructose corn syrups. And they looked at first the weight of the animals, and they found that really there was no difference. It's not like the animals were more fat, more obese. And that's really important because obesity and higher weight has been associated with colon cancer incidence. So we want to take that variable out of this story. So these animals, when the NS means not statistically significant, that these animals weren't that much different in their size compared to the control animals. But when you then looked at what happened with the tumors, you may be able to appreciate here, this is a polyp. Right here, and look how much bigger this polyp is here compared to how big they were in these control animals. And they used a certain kind of mouse that naturally develops these polyps, and showed that, and this just showed that the only thing that was different about these animals versus these animals is that these were given a lot of high fructose corn syrup. And you can see here, this is the size of the tumors. The number here is higher, that these tumors were substantially bigger in size than the animals that were given just water. And so this is beginning, and the paper actually had many other investigations of what the mechanism, like why this would happen, but I find this a very interesting and important paper in terms of starting to actually lay out some of the causative factors that might be true when it comes to this particular thing that is modifiable. Now, fiber has been another thing that has been looked at. There have been small studies that have been looking at fiber over many, many years. Again, associations have been shown, and the biggest study that has looked at this was in JAMA Oncology, which is another one of our big journals last year, where they took 1,500 patients that had colorectal cancer, and they examined them they had filled out questionnaires about how much fiber they took in, and those patients that had the greatest intake of cereal fiber or whole grain, their colon cancer mortality was improved. This is not true for those that were taking vegetable or fruit fiber. And so this is the largest study that suggested that increasing your intake of whole grains or cereal fiber may have a benefit in terms of survival once you already have a diagnosis of colorectal cancer. Another big area of investigation has been looking at vitamin D. This actually came about because we were seeing some associations with people who had low vitamin D levels doing not as well as patients who had normal vitamin D levels. The biggest study to look at this looked at almost 6,000 patients with colorectal cancer and then 7,000 controls, people who didn't have colorectal cancer. And this was the low serum vitamin D. Those people had an increased risk of developing colorectal cancer. And if you had high vitamin D, then you also had a decreased risk. So it was true in both directions. And then there has been an interventional study that took patients that had metastatic colorectal cancer and gave them either high dose vitamin D or normal dose vitamin D. And In that circumstance, there was no difference in survival, but there was decreased progression, meaning that people were able to stay on the chemotherapy longer without their cancer growing. And this was a very small number of patients, only 140. So it's actually quite difficult statistically to show a difference in survival, but this has been an interesting finding. And in my patients, I definitely check vitamin D levels, and if their vitamin D levels are low, I feel comfortable supplementing them. I don't necessarily give them high dose supplementation because this is, again, was a very small study, but I think that supplementing people so that their vitamin D levels go back up to normal makes sense on many levels, including my colorectal cancer patients. There's been some work that has looked at nut intake. Again, the largest study looked at 800 patients and observed, these are the same patients that were then observed for how many servings of nuts they took, and patients that had 2 or more servings of tree nuts lived longer if they had colorectal cancer with stage 3 disease. And so non-tree nuts like peanuts were looked at, and they didn't have this benefit. So you can take this for what you will. If you're someone who really enjoys tree nuts, this might be a reason to consider having more of them. And then aspirin, which has been a huge headache in colorectal cancer. When I first started on faculty over 10 years ago, the first studies showing a very strong survival benefit for patients that were given aspirin that was quite compelling to me, and I was putting all of my patients on aspirin. Again, these were observational studies, but I found them quite compelling. But then more recently, especially a big paper that came out last year in the New England Journal, which is probably our most important clinical journal, looked across thousands of patients that had been treated with aspirin. And in the patients that were treated with aspirin, they actually had increased mortality, and that was particularly true in the cancer patients and colorectal cancer patients in particular on top of that. So that was quite disappointing, and I think it has really created a big question mark around what we should do with aspirin, but right now it's really not recommended as a supplement for colorectal cancer. If a person has heart disease or diabetes or other reasons that they should be taking aspirin, of course that's different. But for colorectal cancer recurrence, I think that that's been the real challenge. And then I just briefly want to mention a few clinical trials that are available. If there is anybody on this webinar that is presently in treatment for their adjuvant therapy, that might be options for you. So this is a clinical trial. So I'm part of the Stand Up to Cancer effort in colorectal cancer. This is a big national effort that's been going on for 10 years for anyone who's not aware of it. That's really been led by Katie Couric and many people in the entertainment industry, and they've raised over $100 million for cancer research and have given it these large grants to different groups to try to work together to improve cancer survival. So we are part of the colorectal cancer dream team, and as part of this study, open at multiple institutions. It will be open here at Hopkins, it's open at the Harvard institutions, it'll be open at Memorial Sloan Kettering, at Case Western. So this is a study that enrolls patients with stage 3 colon cancer, and after they finish all of their therapy, we then do a blood test, and we are looking for circulating tumor DNA. So we're looking to see, can we detect DNA in the blood that looks like it comes from the colon cancer? And if we don't, that's great. We just go on to normal monitoring. But if we do detect it, then we consider putting people on additional therapy or on therapy with drugs that are based on your particular mutational differences. So personalized therapy in that setting. There is also a national trial that's open across cancer centers in America that is looking at microsatellite unstable, so MSI high patients. And these are patients, again, stage 3 colon cancer patients who complete all of their chemotherapy, then can go on to get treatment with immunotherapy combined with chemotherapy versus just chemotherapy alone. This is based on data that shows that patients that have this mismatch repair deficiency, microsatellite instability, which in stage 3 disease is about 10% of patients. But in the metastatic setting, immunotherapy has really compelling benefit for those patients. So now we're trying to see whether we can provide some of this added benefit to people even with earlier stage disease. And I want to just highlight one of our own studies that is being developed here at Hopkins. It should open by the end of this year. And this is for patients that have KRAS mutations. And if they have stage 3 disease that is at high risk for recurrence, meaning there's a lot of lymph nodes that are positive, or for patients with stage 4 disease whose cancer has been fully resected and now they're just in a monitoring phase. This is a clinical trial that after people complete chemotherapy, they would get a personalized KRAS vaccine if they have a KRAS mutation, along with immunotherapy, with immune checkpoint therapy, with ipilimumab and nivolumab for a year. Again, so high risk of recurrence, trying to mitigate that recurrence by stimulating people's immune system with a vaccine plus immunotherapy approach. And then just my last few slides, I'd like to touch on what happens if there is a recurrence. And so this slide, I really just tried to summarize overall, how do we look at people with recurrent disease over the course of their care? So first, I want to highlight that the reason we do this aggressive surveillance is because if we catch a recurrence early enough, when it's still confined to only 1 or 2 organs, that many patients can still be treated with curative intent, meaning that we can operate, we can maybe do more chemotherapy, maybe not, depending on the particular circumstance, and still hope that we can beat this cancer completely and it won't come back. Even in the setting when people have a recurrence with metastatic disease and that cannot be operated on, while chemotherapy does not at this point result in cures for most patients, even the average patient will live for multiple years. And so this really isn't a death sentence. This is a chronic condition that if someone has a recurrent cancer that can't be operated on. And I really do want to say that we are making advances every year in this cancer. Survival is increasing every year. So even if someone has a recurrence today, the hope is that we can use the tools that we have today to keep people around for the big breakthroughs to happen that we're finally getting to in this disease. I also want to highlight for anybody that ends up with a recurrence to please look at clinical trials early in their care. Far too often, people don't look at clinical trials until they've exhausted every therapy that is available in the community. And at that time, often, people's bone marrows have become tired. There may not be clinical trial options because many clinical trials will only let you go on if you've had no other therapy or 1 line of therapy or 2 lines of therapy. So you should get into a center that does clinical trials for colorectal cancer early. It doesn't mean you have to be treated there, but setting up that relationship early in your disease course is really important to give you the best scope of options. Every patient should have testing for KRAS, BRAF, and NRAS. These are 3 genes that help determine what kind of treatment options are available. There's some drugs that work or don't work based on that mutational status. That's done in the tumor based on the previous surgery that you've had, so you don't even necessarily require a new biopsy for it. And microsatellite instability, I touched on that before, that in the recurrent setting, that's only 3 to 5% of patients, but in those patients, immunotherapy as a single agent has dramatic and sustained benefit, with some patients having significant reduction in their tumor or even complete eradication of their tumor. So everyone should have MSI testing done as part of their treatment. And then the other thing is that if you have a left versus right-sided colon cancer, it makes a difference in what treatment you should get in the first line. And there's a lot around this, but my general advice here is to make sure that you have your doctor explain to you what their treatment choice is and how that fits in with the fact that your cancer is either right versus left-sided. I also want to speak to how much exciting research is ongoing right now in colorectal cancer. I mentioned immunotherapy first, not necessarily because I think it is the most important. I do think it's very important. It's been groundbreaking in many tumor types, but it's mostly because right now 70% of drug development is happening in the immunotherapy space. We really need to find a way to get these drugs to work for patients that have microsatellite stable colorectal cancer. That's the 95%. Epigenetic therapy, which focuses on how the DNA is actually expressed, how the genes are expressed rather than mutations. Molecularly targeted therapy, these are treatments that are aimed at personalized treatments aimed at what is abnormal in the DNA of your given cancer versus another one. There are new chemotherapy agents that are coming out that we shouldn't forget about. And then really combination approaches of all of these are where I think a lot of excitement is. So immunotherapy, when people talk about immunotherapy, a lot of times they're talking about immune checkpoint inhibitors, PD-1 and PD-L1 therapy. PD-1 and PD-L1 therapy is just one part of immunotherapy. The way that a cancer interacts with the rest of your body has to do with much more than just this immune checkpoint. You have many different kinds of immune cells that some are good, some are bad, that we can try to modulate. There are things around the tumor, we call that the tumor microenvironment, the environment around the cancer. And in that area, there are also things that we are trying to modulate to help the immune system work better. There's vaccine-based therapy. But the one thing I want to mention, because I've seen this happen far too many times, is if you are in the community and your doctor in any way suggests that you should get a PD-1 agent and you do not have microsatellite instability, the answer to that should be no. That will deny you eligibility for all clinical trials, most clinical trials that are testing immune checkpoint inhibitor therapy, and study after study has shown that there is a 0% response rate. It does not work by itself. Now, there are responses that are being seen when we combine some of these different kinds of drugs, and that's all being done on clinical trials, but it's just something that I wanted to highlight. Epigenetics and genetics, these are treatments that are working on how the cancer cell is actually expressing genes. So just a basic biology lesson is that DNA is the fundamental building block of life, but DNA has to be converted into eventually proteins. And proteins are actually what do the work of the cell. And so mutations in the DNA or normal DNA that results in abnormal proteins or abnormal numbers of proteins, that is genetic and epigenetics interacting with each other. And we have many drugs that can affect this component. And in particular, I think what's exciting is that when we put these things together, we're actually able to potentially change the underlying biology of the cancer and make the cancer cell less malignant, make the cancer cell more sensitive to chemotherapy. And I think that's what's, and immunotherapy for that matter. And I think that's what's very exciting about these kinds of drugs. And then I want to give, just as we end, one example of what we are doing. This is just one study, but work like this is ongoing, and I hope that it leaves everyone on this call feeling very excited and hopeful about the direction that we're going. And so what I want to talk about is some work that was done in the laboratory by one of my collaborators, and her name is Natalie Collins, and she's works out of Boston at the Harvard institutions. And what she was interested in doing was trying to identify, are there some mutations, when you send your tumor for sequencing, are there some mutations in the DNA that are more likely to sensitize a patient to getting immunotherapy, or more likely to predict that a patient would be resistant to immunotherapy. So what she did was implant cancer cells in mice, and each one of these cancer cells had a different mutation. So it could have had a KRAS mutation, a BRAF mutation. She actually implanted them with hundreds of different mutations and waited to see which of those cancers grew, and then treated them with PD-1 inhibitors. And what she found was that if that mouse had a tumor that was mutated in one of these genes. PI3 kinase is a gene that's mutated in about 20% of colon cancer. That if you had a mutation in one of these genes, that you were more likely, this is what happens with resistance, you are more likely to be resistant to the PD-1. And when she then went back and treated those mice with a PI3 kinase inhibitor and the PD-1, the tumor was really able to be completely controlled. So the combination of a PD-1 inhibitor, the immunotherapy agent, with the molecularly targeted agent really resulted in very nice control of the cancer and even regression in these animals. And so based on that, that's how we design clinical trials. And so in my opinion, the best clinical trials are trials that have some sort of rationale based on what we're seeing in the laboratory, and then we say, let's try this in patients. And so we presently have a clinical trial that's open here. And again, this is just one study of dozens of studies that are being done that are looking at rational approaches to combining therapies. So we give a PI3 kinase inhibitor with a PD-1 therapy, a PD-1 agent to patients with colorectal cancer. And now that we've found a dose, we are looking at people that have mutated PI3 kinase just to see whether we are able to identify the small subset of patients that might be really sensitive to this combination approach. So I'm going to end there. I hope what I have shared is that when it comes to treating colorectal cancer, especially in early stage disease, the paradigms are very standard. No matter where you're being treated, not only around the country, but around the world, you can feel very reassured that it's a very standard treatment paradigm and that you're getting the best treatment options in anywhere that you're being treated. There is some uncertainty how much we can change some of these lifestyle factors to affect outcomes, but I wanted to share with you just a few that might be interesting. I believe every patient with a recurrence should get a second opinion at an academic center early in their diagnosis. If you're already at an academic center, I also don't think it hurts to go get another opinion at another place. You know, it's a serious diagnosis, and anybody that, any provider or doctor should be okay with the idea that you want to just get, you know, one more cook to give their opinion about what's going on. And finally, that there really is a lot of exciting work being done, and that I really think we're on the precipice of making a huge difference for how we treat this cancer. And with that, I'm happy to take any questions.
Thank you so much, Dr. Azad. What a great presentation. Just a reminder to everybody that's listening in, there's a little box on your control panel where you can type in questions. And if you go ahead and do that, then we can, I'll go ahead and ask those questions on your behalf. So we do have a few that came in already. So I'll go ahead and start with those. Let me pull them up. Okay. So this question is clarifying around, they're looking to understand what not to do if you had a PD-1 therapy. So I believe looking for clarification on PD-1 immunotherapies and how that could change future treatment options and why.
So can you read that question again? I guess I just want to make sure I'm answering.
So they said, what was it that you mentioned not to do if you have had a PD-1 therapy?
Oh, no, what I was saying is that nobody should be getting a PD-1 therapy alone if they don't have microsatellite instability. So I have seen people in the community that have gotten treated with a PD-1 inhibitor like Keytruda, pembrolizumab, or Opdivo, nivolumab, off-label, even though they had microsatellite stable disease. They didn't have that marker. And I just wanted to caution people about that, because then in the future, other clinical trials are going to make it, it's going to be difficult to qualify for other clinical trials, because many clinical trials say if you've ever had exposure to an anti-PD-1 therapy, you can't go on that trial.
Got it. Thank you. What are your thoughts on maintenance therapy in between occurrences?
On which therapies in between recurrences?
Maintenance therapy.
So, you know, maintenance therapy has only been proven to have any benefit And that benefit was really inconsequential in the metastatic setting. So in the metastatic setting, when we know someone definitely has cancer, like you definitely have it, you can see it on a scan, if you give someone maintenance therapy, the difference between giving someone maintenance therapy and not giving someone maintenance therapy, both of those individuals are going to, on average, live just as long. The only difference was that people will live a longer amount of time without their cancer growing. But in the end, it doesn't result in a different survival benefit. And so that, because of that, in Europe, very few countries actually give maintenance therapy because it doesn't have a survival benefit of because that's what matters, is how long someone is living. Now, in the United States, maintenance therapy for patients that have metastatic cancer, stage 4 cancer, is standard and everybody does it. But there are definitely times where people have a high risk of recurrence. So if you've already had metastatic cancer once, twice, and you have it resected, now should you just go on maintenance and try to keep it from coming back? And there is zero data to support that. And even the data that is in the metastatic setting doesn't have a survival benefit. So while I have seen it done, I just don't know why. I don't know why that happens. But I am not in favor of that.
Wow, super interesting. I did not know that. Okay, next question. Realistically, how far away are we from immunotherapy for KRAS wild type non-mutant, or is there another better emerging cure in the space?
I think that we are 3 to 5 years away, and that's only because even if a trial has some, is promising, you then have to take it to a bigger trial and a bigger trial. So it's the timing of trying to get that done. But there are so many strategies that are being tested by different groups right now that I think there's a strong chance that in a small study now, there's something that will work for many patients. It's just that we're still in the early stages of it, and it takes 3 to 5 years to take any strategy and move it forward. But there's just so much work being done in this space right now. So I mean, I'm knocking on wood, but I am optimistic that we're getting closer and closer.
That's very exciting to hear. Thank you for that. Wow, we are having questions just like flooding in, which is awesome. So this question is for a stage 4 patient whose scans are no evidence of disease with a CEA that's rising. Aside from, looks like going for a second opinion, and asking if, what else can they do aside from exercise and healthy eating? What kind of other lifestyle things can be done to help this situation, if any?
Yeah, I mean, so I tried to pull out the things that I think that there's any real data for, and so I think those things that, if you wanted to, the exercise interventions have actually been really hard. It's just very hard to do a trial where people are compliant with doing exercise in a certain way. But the vitamin D, the nuts, the fiber, like those things you can do. If someone's CEA is rising, then I think that the most important thing is to just be getting serial imaging very commonly. So, that 6-month surveillance window that was in the NCCN guidelines. In this setting, I would, in my practice, I would be scanning someone every 3 months, and I'd probably, I would want to try to catch this possible recurrence as localized as possible, so we might still be able to do surgery on it.
Thank you. Yeah, so all those things that you touched on earlier in the webinar could be easily implemented in terms of like a lifestyle thing that someone could do. All right, so if you are initially diagnosed stage 1, 2, or 3, and then have a recurrence, is there a predictor for what stage the cancer is likely to come back at?
If someone has a recurrence, the most likely recurrence is going to come back as stage 4 disease because the local cancer has generally been treated. In rectal cancer, if a person has radiation, the recurrence rate is less than 10% locally. And so then there's definitely the chance of local recurrence because it's 7 to 9%. But if you've got general colon cancer and it comes back, it usually will come back as a metastatic deposit somewhere.
Is there any particular serum level of vitamin D that you target for?
I just target for normal because, again, as I showed you, the data for it is not strong, but vitamin D is something that even in normal preventative health, we try to make sure people are on vitamin D at a certain age. And so I feel comfortable saying, okay, but, be on vitamin D and targeting normal levels.
Okay. I think this is kind of a two-part question. So do you recommend retesting the tumor at each recurrence to see if it has changed? And is it possible for the tumor to change from microsatellite stable to MSI?
So those are fantastic questions that come up all the time. There have been some people who have looking at metastasis versus primary tumors and found that there is no difference in microsatellite instability, though the numbers have been small. But so we don't think that you retest for MSI. And the reason that someone becomes microsatellite unstable is because of one of 4 genes being abnormal. So you wouldn't expect that those particular genes out of the tens of thousands of genes that happen would get hit again. Now, in terms of doing repeat molecular sequencing, in colorectal cancer, we haven't done that. The reason is because there's nothing that is actionable based on that. So actionable means you do something different. So people, if they develop mutations, in general, you look at people would develop resistance mutations to a therapy. Not that someone develops a new mutation that now they can get a treatment that they couldn't get before. And because of that, because if things go in a direction, it's for more resistance, not for more activity of a new drug, and you're still going to march through the treatment options that you have, repeat testing has not been done. If you look at people who've had metastasis profiled versus primary tumors profiled, there's significant commonality between the two. And so there are some things that change, but there's actually things that will change in a tumor. Like if you left a tumor in place and you just went back, there's no reason you would, right? But if you left a tumor in place and 6 months later, a year later, went back and sampled that tumor, there would be some changes that happened over time anyway. So that's a long-winded way of saying that there's no need to reprofile.
Great, thank you so much. That was a really clear example and explanation. Kind of along the same thread, if someone didn't get their tumor tested, biomarker testing on the tumor itself, is it possible to have a liquid biopsy done instead, or would it just be done on the tumor tissue?
So it's always best to do it on the tumor tissue. You can do a liquid biopsy, but it is less sensitive, meaning that if you have a certain mutation, then you're less likely to pick it up. And there are some more complex molecular abnormalities that are very difficult to detect in the circulation. They're rare, but they're difficult to detect. So what happens with circulating tumor biopsies is that if you see a mutation, then it was helpful. If you see a KRAS mutation in the blood, then you know that you have it. If you don't see it, then you don't know if it's because it wasn't a sensitive enough test and we just missed it, or that you really don't have it. And that's why it's always better to profile the tumor tissue, because then you can be certain that it either is there or not there.
Thank you. And in terms of the high fructose corn syrup, is this something that's that you see being studied now in humans as well?
The investigator that was the senior most important, I shouldn't say most important, forgive me, the senior investigator on that trial has been trying to figure out how to do this kind of a complex trial. You could imagine that it would be very difficult to do a study to follow this in human beings. You can't leave polyps in place and give them high fructose corn syrup or not. That wouldn't be ethical. And so, you would have to have a large cohort of thousands of patients that get colonoscopies and then also, know what their high fructose consumption is. So I think it's going to be very hard to study it in human beings. I will say that this data is quite strong in terms of what we're seeing in the animals, And so I know that he has been on a mission to try to get a warning label put on put on soda, for example, to say that this could be harmful, the same way that there is on tobacco. I don't know if that will go forward. There's just so much more information on tobacco and its carcinogenesis than on this. And the consumption of high sugar and high fructose corn syrup is so ubiquitous. I mean, it's in almost everything. So very few people won't have had significant exposure to it. So I think that's the challenge with it.
Yeah, really, really interesting. Interesting study. Thank you for sharing that. Let's see. When does HIPEC become an option on recurrence versus standard of care?
So HIPEC is an option as soon as a person is assessed by a HIPEC specific surgeon who feels like they can get it all, and in concert with a medical oncologist who thinks that it makes sense based on someone's disease biology. So HIPEC, just for everybody, is hyperthermic intraperitoneal chemotherapy, and it is appropriate for patients that have disease that comes back or is present only in the abdominal lining, the peritoneal lining, and nowhere else. And so that's the standard of what we would use. You can come to institutions like ours where we do some kind of cowboy stuff. So sometimes we will take people to the OR and do HIPEC even if they have disease elsewhere. But it really requires a multidisciplinary team to determine how to sequence chemotherapy, how long to give it, how to do the surgery, and make sure that we're doing it safely. And I think this is generally true for, I give chemotherapy, so I'm very comfortable giving chemotherapy. If you go see a surgeon who does HIPEC, they will be very comfortable doing HIPEC. What you really want is a situation where you've got people who are on all sides of the debate that are going to be sitting down together and making a choice, and giving you advice together to make sure it's the right thing to do, because it's a very big surgery that has a lot of potential complications and hit to people's quality of life. And it's absolutely the right thing to do in the right circumstance. But, we definitely I've seen patients who have been taken to HIPEC that should never have been taken to HIPEC,
Thank you. Let's see. Okay, a few more. Does the rate of a rising CEA once it is past the high cutoff normal threshold give a person any information on whether the recurrence might be local or distant metastasis?
No, it hasn't been so well predicted. I mean, and CEA can be all over the place. So there can be people with a lot of disease burden whose CEAs are 20, and there can be people who have, CEAs that are in the hundreds that don't have that much disease burden. So it just isn't that great of a marker, to be honest, and we're looking for new ones.
Thank you. Would non-operational nodules in the lungs ever become operable, or is it not worth doing since the cancer is systemic anyway?
I mean, lung nodules are similar to liver nodules, that they can be resected for curative intent depending on their distribution. So if there's only a couple, then they can be resected. Sometimes what I think the challenge with lung nodules is sometimes people will have widespread lung disease, and then you can't unlike the liver, it doesn't regenerate, so you just can't take out that much, and then it also is speaking to it as being systemic and in multiple places, and you're not really dealing with the underlying problem. Now, we have had people who've had, let's say, 5 or 6 lung nodules, so not just 1 or 2, but not 20 or 30, and after chemotherapy, that a couple of them have disappeared, and now there's only a couple that are left. And that's kind of, I think, the quandary. That's the question mark at that point is, was this systemic disease? We should never take them to lung resection, or should we still consider it? And depending on how out of the box your team is, and how long your cancer has been under control, in that circumstance, you would want someone to go many months, maybe even a year, with their cancer being under control before you would go after those last couple that are left. So it, again, just speaks to the importance of being, in these complicated circumstances, being in a place that, or going to visit a place that has a lot of different kinds of expertise and different kinds of eyes looking at your case.
Thanks, Dr. Azad. We have time for one more question, and apologies to those we didn't get to we can follow up in a blog post. So I have your questions here. So our final question, I don't know if you can truly answer it, but I guess it's your thought process. So do you think that maybe a contributing factor to young onset colorectal cancer could be the high fructose corn syrup, as it's something that was kind of introduced, I believe, in the 70s?
Yeah, absolutely.
More research needed, yes.
It's not even more unfortunately, it's going to be one of those things that we're uncertain about, but the way to do those kinds of studies is to go look in other communities in other countries where there's not as much exposure and see how their rates are changing. That'll be a little bit more support for that hypothesis, but it's never going to be a perfect, analysis.
Okay, well, thank you so much, Dr. Azad, for your time. It was a great webinar, a great presentation, and thanks for taking the time to answer all of these questions. Huge thank you. Yeah, thank you so much, and thanks everyone for joining live, and have a great day.
Okay, bye-bye.
Bye.